Welcome everybody to the eye care experts, Dr. Terrezza, Dr. Bell, and Dr. Sahawneh. As far as topics for today, I guess we could, a lot to talk about here because a lot of different symptoms and complaints patients will come in. But how and why and when shingles affect the eye. As far as whether it's shingles or herpes or simplex or herpes zoster, what do you usually get as far as complaints? I guess patients calling up where.
I think it's never on someone's radar. It's never on a patient's radar. They usually think that they either scratched their eye, got something in their eye, they think a contact is stuck in their eye. It's usually a complaint that's not related a diagnosis that they are even considering. So usually it's an incidental finding because we know what we're looking for. And that's something that it's kind of really non-specific symptoms. We've got red eye, pain, light sensitivity. They think something's in it, feels like maybe a rock, really gritty, hurts a lot. And so that's something that when we're going through those non-specific symptoms, it's on our list of differential diagnoses that we're always kind of looking at to see, is this what we're seeing? And I will say it's a lot more common than people think. It's a lot more prevalent, and it's one of those kind of masquerading things that if you're a doctor and you're not looking for that or actively thinking about it, you can miss it, and it can hurt and really take off on the eye, unfortunately. And it's something that if you don't treat it, it won't get better, or it can get a lot worse.
For sure. And that's certainly putting stain in the eye, whether it's the normal fluorescein or even some of the more specific stains that we have. Stain in the cornea, kind of looking, it certainly helps differentiate,
Yeah, there are a couple different stains to use. Yep. And that when we're talking about staining the cornea, we're talking about the clear cornea, the dome of the front part of your eye. There are certain dyes that we can put in the eye that will be absorbed into certain layers, and that will help us determine what damage could be there and what layers or to what effect is your eye unhealthy.
And with, whether it's herpes simplex or herpes zoster, the eye could be affected and could not be. Sometimes it's just the skin itself, whether it's the forehead, whether it's the eyelids, underneath the lids. Sometimes there are dendrites on the cornea. Sometimes the cornea actually looks pretty clear and it's just the skin. But usually, when we get to a certain level, it's usually half. It's one side, like the trigeminal nerve, so it's not usually on both sides. It's usually one side that's affected.
So you're talking about shingles.
Yeah.
And so the shingles is the herpes virus where it's been laid dormant in your body since usually you've gotten chickenpox when you're a child or at some point in your adulthood. And that virus is not completely cleared by your body, and it will land in certain sensory pathways along your body. And then there's an initial insult or something that can happen that will let that virus take over and flare up, and it will happen in certain portions or certain dermatomes of your body. And so he's talking about the dermatomes that are along the facial pathways along the eye, along the forehead, eye, and then sometimes down in
heat, stress, certainly things like that. There are patients that we see that may have it happen one time, and I have some patients that I see every 3 or 4 months. So it really depends on the patient, how often it presents. It can be an acute issue, it can be a chronic issue, but certainly it can be painful. It can be painful.
Oh, that's without question. Yeah. All these patients are some of the most in-pain patients you'll see at some point. So zoster is very painful. That's I think one of the very first symptoms is tingling. You'll have like really, really sensitive skin along certain scalp areas, and then it will kind of spread down through. And so a lot of times we see patients who have already presented to an urgent or emergent care and had the diagnosis of zoster or shingles, and then they're told to follow up with an eye doctor, because what we're looking for then is, yes, we see it up along your scalp, we see it, you're obviously presenting with it, but then we are looking for inside the eye inflammation or infection that can kind of go through, and if that's not addressed properly or treated, that can be very devastating to the eye. So when we're talking about shingles, yes, you've got the external things that you're seeing and presenting for, but we as eye doctors are looking inside the eye, on the eye, to see, is that something that we need to continue to treat? So that's zoster, but then on simplex is the very front of the eye, and that's what we're looking for. And those are the ones that come in with the red non-specific pain. So we have 2 different symptoms for 2 different ways that the herpetic virus can show up in the eye.
10 to 20% of the shingles cases involve the eye. Give you a rough idea of that.
That's a lot higher than I would have thought, actually.
That's what I thought, yeah. Well, I got it from the article. I didn't just have that on the tip of my tongue.
Yeah, I mean, I think your point certainly there's not many patients, unless it's been diagnosed by urgent care hospital, are not going to come in and say, hey, I think I have, shingles or I have herpes or something like that. But, they will come in with pain, they will come in with burning, itching, all these different complaints. And certainly that's part of our job, as far as looking at everything, taking all that into account, looking behind the slit lamp, looking at the cornea itself, looking at the eye, looking at the eyelids, looking at the forehead, looking at the skin, looking at all those things to determine, when we talk about, red eyes, or patients will come in and say, I have a red eye or have this or have that. Well, it could be bacterial, it could be fungal, it could be dryness, it could be viral. And these things are not always treated the same. In fact, that's the big, we've got to figure out, what is the culprit here, because, what we give for bacterial may be different for viral. Maybe this condition we need to start them on an oral. This one we may just go with a topical, whether it's a drop or an ointment. So all those things are important to figure out what is causing the condition, what's causing the pain, what's affecting the eye, the best way to treat it.
Systemic conditions, too, can mimic some of this. Rheumatoid arthritis, to mention one, and the other disease entities in the arthritis family. So you have to be careful.
And I will say, even it can be something so nondescript. So I've had patients who go through just any stressful time, whether it's a loss of a family member, whether it's coming up to the holidays or coming up to the holidays. Holidays can be very stressful for people, and it can be something as simple as a stressful holiday time that can let our immune system be just compromised enough, and this virus can take over. And it doesn't even have to be anything that you did as a patient that triggered an insult. It can really just be stress, grief, school, lack of sleep, all of the different lifestyle factors that will just let this virus kind of show up. And then that's when, unfortunately, we really do have to take control and treat it so that ultimately there's no scarring or permanent damage done from it. But then that's really one of our roles, is to continually educate the patients and say, there's not like a cure of this. The goal is to make it go back dormant and let your body keep it dormant. So like you said, there can be reactivations down the road, which can be very painful, but if you really get those diagnoses and treatment right, you can stay on top of it and manage it. And then if you let your patient know, stress can do this, it can be another reason to have them help out as far as their stress lifestyle and what they can modify.
Here's a question for both of you, and I think literature's changed a little bit through the years when I first started, but let's take a case of a patient who has herpes simplex. They have forehead affected, they have even dendrites on the cornea. In that case, and the patient's painful, things are going on, would you start that patient on just a oral antiviral, or would you do an oral and a topical at the same time? What do you think?
Usually an oral is going to be good enough, but I will say it depends on the patient and their stress and immunocompromised situation. So typically, I'd say majority of my patients respond really well to an oral alone. There is a topical that is very, very good. It's sometimes very hard and expensive to get. So that's the other thing, that when you're looking at your patients, how can we treat them? An oral is usually a much easier route to go, and it's very effective. If we can get them on a topical, and that's what their condition necessarily calls for, to me it just depends per patient and what we can get them on.
Yeah.
With me, and I don't want to appear cynical,
Yeah.
but it depends on if they have insurance or not, and the type of insurance they have and
Sure.
what's covered by their insurance. So if I look at the case and it looks pretty rough, I will do the oral plus a topical, and I'll blast it on both ends to get those symptoms down. If I'm not sure and they have no insurance, then acyclovir is the cheapest of all the drug entities there are, and I go with that.
What about seeing that patient back? If you say you start them on an oral or maybe an oral and topical, when would you normally see them
Regularly.
back?
I like to see them every couple days. If their schedule allows it, my schedule allows it, I want to make sure that I'm staying on top of that, because the cornea is so delicate, their pain is so delicate. Honestly, some of these patients are in so much pain, they want to make sure things are going better. So, and then if it's not, then we can get them to a specialist or make sure there's not something else going on. So I usually, if not every day, every other day, or every every few
I
days.
think we agree with that. I mean, because certainly for the pain, we want to make sure you're feeling better, but also we want to make sure if we're starting you on a medication that we see some improvement over a couple of days. If there's not improvement, you know, we may need to switch up or do something a little bit different.
Yeah, better to oversee them than not see them enough.
Yeah, there are some conditions where we feel like patients sometimes will say, hey, the pain's more than the condition, but these right here, this is legit. These patients, and I'm actually surprised sometimes when patients, and I look in the eye and it's bad and they're not complaining about more pain as they are, because I know usually these patients are hurting.
Yeah, I do try to validate the patient's pain a lot too, because I'm saying, you know, the eye has some of the most sensitive nerve endings in the human body, and I'd like to remind people of that I'm like, you're not being over dramatic, you are in a lot of pain, I see what you're going through, and I want to help.
Well, one of the things you said there, medication-wise, I think is key. When I first graduated school 20-something years ago, it was a little different than it is nowadays, where we could pretty much prescribe what we thought was the best, you know, medication for that patient, whether it's a topical or an ointment or an oral, and the insurance would pay, and it was just, you know, everything was done. It was a very quick, easy process. But it seems like today, you know, we've got to look at the insurance. We've got to figure out, hey, what's going to be best for the patient, but also which is not going to cost them an arm and a leg. And so it's not that we're sacrificing care, but I just want it to be known that we certainly, all of us, take patients into account. We try to do based on what, you know, whether you have no insurance, or whether you have this insurance or that insurance. We want to get you treated with the best we can, but we also are cognitive. We don't want to send you to the pharmacy and the bill be $500 either. So we certainly are always looking and say, hey, based on all these factors, this would be the best drop for you. This would be the cheapest for you. This generic may be better. This brand name may be better, but we're always thinking of that.
Speaking of that, when you talk about insurance, we have an insurance staff of 5 people that go over billing and bill for you. And in addition, the staff is trained to look up your medications and which ones are covered by your insurance or not, so you don't have a pharmacy surprise when you go to your drugstore of choice.
And I will say that sometimes it just having that conversation with the patient ahead of time too. And unfortunately, both types of herpetic infections, both Simplex and Zoster, can leave really bad scarring in the cornea. And some people really do end up with a loss of vision because of these cases. So sometimes if it's bad enough, sometimes we also just have to have that conversation with the patient and say, look, I know you might not have the coverage or anything like that, but we will always try to work something out to try and help this patient's eye to get some sort of coverage, to get some eyes on it, to get some sort of treatment going, because if you leave it unchecked, it unfortunately can progress to where it can be a sight-threatening condition. And so that's something that when we're talking through having somebody help, family members, FSA, HSA, gift cards, things like that. Yep. I mean, any little bit can go a long ways to try to help prevent in acute cases like this.
What about vaccines? I mean, I've had this come up, I guess, in the last week. What would you guys, for Shingrix and some of the vaccines?
I think there's a pretty large, I can't quote the exact percentage, but I think the patients who get Shingrix have a very high percentage of not having this occur in the eye. I might have said that in backwards, but essentially if you get the vaccine, you have a very low chance of having the actual Zoster outbreak specifically on the eye. It can help quite a bit.
I guess the question I got was, when can I get the vaccine? And I guess one of the precautions, you certainly don't want it to be active at that point. You want to wait for it not to be active. And I think age-wise, we usually, and it may have changed, I've always heard kind of the 50, usually 50 and older are usually the best ones to get Shingrix.
That's correct.
But I think it's because we've seen some, especially for patients who have a chronic issue with it, and it's flaring up, once a year, 4 times a year. And again, getting nasty, if you told me, I could get a vaccine and it would lower the chances of this happening again, and I don't want to, I never tell patients what to do. I kind of say this is what I think is best, but I would lean towards getting the vaccine, I think, in that condition.
I think any patient who's gone through the pain of it would tell you would tell you if there's any way you can avoid it or even have a less severe case of it. I think that almost everybody would take that.
And I think it's a 2-dose deal. I think it's 2 doses, and I believe most medical insurances cover it. I could be wrong on that, but I think that's true. Anything else on the shingles or zoster or herpes simplex as far as you've seen, or anything we didn't cover as far as education or recommendations?
I mean, if you're having the symptoms, give us a call. It's always better to check it. I think a lot of misconceptions about herpetic cases is that they think it's a pink eye or just a run of the mill. Oh, you know, my kid came home from daycare with something and I now have a pink eye, but it's not getting better. It's getting worse. It's getting more painful, more light sensitive. Always call us. We really try to work those patients in as best we can because we know those cases can have pretty devastating outcomes if not addressed.
Well, we're lucky enough at each of our offices where we have slit lamps, we have stain, we have BIOs, we have a lot of things that we can actually see the cornea and the eye, you know, really well. And unfortunately, there's places that patients may go to that may not have all the tools that we have. So, you know, that's the reason, you know, certainly we want you to give us a call. If you're in that much pain, we're going to try to work you in as soon as we can, if not the same day, certainly the next day. But give us a call. We're here Monday through Friday. We have some offices open on Saturday, but we'd much rather you come in to see us than go to urgent care somewhere else that you may be waiting for a while. And who knows, they may not have a slit readily available to even kind of look at the eye and help you the best they can anyway.
I would say that if you have visited a telehealth provider or other urgent care or what's the other word I'm looking for, like an emergency room, and you find that your pain increases despite taking the medications prescribed, then it's good to make a move. Come see us. Yeah.
So certainly, you know, again, you may not come in saying I have this, but any of those, especially if if the pain resides and it doesn't go away, the redness resides, the tingling, the burning, and it's lasting more than I would say a day, but certainly any of that with certain level, you know, let's come in, let's figure out, is it bacterial, is it viral, is it fungal, is it just allergies, are they really dry? You know, we talk about conjunctivitis and red eyes, but there's so many things that can contribute to that. And that's the reason we've got to figure out, you know, what the cause is, and then figure out the best way to treat you, get you feeling better, and hopefully get it to where it doesn't get to where it gets to that level where it's so painful.
And a lot of these antivirals that have such a nice safety profile medication-wise is that sometimes it really is just a simple fix to just put you on an antiviral. It's a very safe medication. It can help all of that. And so that's something that it's really sad to see some patients just suffer with this or have vision loss from scarring or anything like that. So that's something that if you are having those issues, don't wait.
Yeah. Or I've had this happen with contact lens wearers, maybe had this or that last time, and then it flares, you know, they get kind of what they feel like the same symptoms again, and then they say, oh, I just used the drop that I got last time. And this time, maybe it's a different condition, and the drop they had last time makes this condition worse. So, you know, sometimes it's the same thing, sometimes it's different. So don't always assume if you're using a drop and it's not getting better, and it's still hurting you, you know, give us a call, come in. Visit us at TerrezzaOptical.com. How many locations do we have now? We've got eight locations. We've got 13, going on 14, I think, optometrists. And we certainly want to see you. We want to help you the best that we can. We appreciate you watching the podcast. We appreciate Dr. Sahawneh joining us. Thanks to Dr. Terrezza. I'm Dr. Bell. You know, if you've got an HSA, flex spending, end of the year, come in. Whether it's materials, whether it's something you need, whether it's medications, whether it's, you know, an exam, an office visit, whatever you need, come in and see us because we certainly want to help you. I can't believe we're already at the end of 2025. It's crazy how time flies. But, well, thank y'all. Thank y'all for watching.